Hello, my name is Casey Ugochukwu. I'm a family nurse practitioner student at University of Houston College of Nursing, and today I'm going to be presenting to you guys a case study on the management of health disorders in adults. Okay, so for every contact we come into with any patient, we want to know in their own words exactly what the chief complaint is. And for this patient, it is, I am having a burning pain in my chest. It feels like a really bad head burn. History of presenting illness is that she's a 66-year-old female. She was transported by the paramedics to the emergency department of a local hospital with severe burning substernal chest pain for the last 3 hours. She states that she was fine until about an hour after breakfast. The pain does radiate to her back and is accompanied by a mild shortness of breath. She has some nausea, vomiting, and a sense of impending doom. In the ambulance, she got 3 sublingual nitrates and the chest pain was unrelieved. Now we're already thinking, okay, what's going on with this patient? Is it a STEMI? Is it a non-STEMI? Is it a heart failure? Is it unstable angina? Is it a PE? Is it a pneumothorax? There's so many things, pericarditis, aortic dissection, but we don't want to jump into any conclusions because it could be any of these, so we're going to rule out every possible ones that we can. Past history, we don't get a past history, a really quick one because we don't want to waste too much time collecting this history. She did have hypertension for 20 years. She's a type 2 diabetic. Her lipidemia 20 years ago. Her ovaries is intact. She does use alcohol 1 to 2 drinks per week. She quit smoking 20 years ago, which is a good thing. However, we don't know if she uses any kind of drug. We didn't ask her here, so her family history, she has a big risk factor here. Her dad died of a myocardial infarction at 54, and that's a really big risk factor for heart disease. Mom died at 80 of breast cancer. Brother has hypertension, he's 58. Sister is 61 and she's alive and well. Now she also has a risk factor. Other risk factor she has is that she's 66 years old, so that she's older, and she's also past her menopause, so that's big risk factors for heart disease. Allergies, she doesn't have any allergies that we know of. Her meds, she takes amlodipine 10 milligrams, PO means by mouth, every morning for her blood pressure. Glyburide, that's for diabetes. She takes 10 milligrams by mouth every morning and 5 milligrams by mouth every night. They'll take enteric-coated aspirin, and that's an antiplatelet, 375 milligrams by mouth every day. And she takes gemfibrozil, which is a lipid, and it helps decrease cholesterol and triglycerides. She takes 500 milligrams by mouth twice a day. Review of system basically is what the patient tells us, and the only thing we have for this case study is that she's positive for baseline chest pain and for some time. Physical exam, which is what the clinician would do by himself, is she's well dressed and well nourished female. She's 11 rated times 4. She's in moderate distress with chest pain, obviously. Vital signs, her blood pressure is not too bad, 145/89. Heart rate is 89. Respirations is 18. Temperature is 37.1. She's 5'10", and she weighs 86 kilograms, and she's a little bit overweight, which is also a big risk factor for heart disease. Now, there's something missing on this vital sign. She does not have an oxygen saturation. And we really need to know what her O2 sat is because that's going to affect what kind of treatment we give to her. HEENT, which is head, ear, eyes, nose, and throat. Perla, pupils equal, round, reactive to light and accommodation. Extraocular movements are intact, and tympanic membrane is intact. Her neck is supple. She has mild jugular vein distension, which could be pointing towards heart failure. But we don't want to jump into any conclusion yet. She has no enlarged thyroid. Lungs, she does have some crackles and rales. It's also indicative of maybe heart failure. Cardiovascular, PMI, point of maximum impulse, is displaced. She has regular S1 and S2, no S3 and S4. She does, however, have a grade 1 systolic ejection murmur at her left upper sternal border. Now, the PMI and the murmur, the PMI displacement and the murmur are indicative of heart failure, and it could be seen and also in patients with cardiomyopathy and ischemic heart disease. Abdomen is soft, non-tended, non-distended. Liver span is tended, 12 cm, no bruise. Musculoskeletal and extremities, she has full range of motion. Muscle strength on her right side it's 5/5, and then her left side she's a little bit weak. pulses are 2 pulls on every extremity. No femoral bruise or peripheral edema. Neuro, she does have decreased deep tendon reflexes on her left side, and her cranial nerves are intact. She's negative for Babinski. Lab. So this is a very, very important part of the whole process. This is where we want to like focus on, like really to figure out what kind of problem she's having. If a patient comes in with chest pain, you want to look really want to get her troponin, want to get a lipid profile troponin, and want to get an EKG. And EKG, you want to get that within 10 minutes of the patient arrival. In this case, she does have an ST segment elevation and leads V2 and V2 to V6. Troponin is 0.3 and the normal is 0.03. So it's pretty elevated. And this is the troponin I is the most specific indicator for MI. So, and it usually determines the size of, it's used to estimate the size of the infarct. Also want to look at her kidney functions. BUN and creatinine is pretty good. 16, creatinine is 1, so it's on the normal side, so we know that she doesn't have any kidney issues. We also want to look at the electrolytes, especially potassium and magnesium. Potassium looks good and magnesium looks good. Her lipid profile is not very good. She has total cholesterol is 214, which is high. HDL is 35. We want that to be on the higher side, greater than 55. LDL is 144. We want that to be lower, and triglyceride is 175. We definitely want that to be lower. Looking at her blood count and all that stuff, hemoglobin and HCT is all looks good. So now we are basically shortening our length of diagnosis to like maybe a STEMI. Or we still don't know if she's having a pneumothorax, so we don't want to count that out until we've actually checked it. Differential diagnosis, I have 3. One is the ST elevation myocardial infarction, and this is because the troponin is elevated, and which is the main indicator of an MI, and then her EKG shows ST elevation. So these are indicators of an MI. Also put aortic dissection because ST segment elevation is also seen in aortic dissection, and it comes with chest pain and shortness of breath. So these are all still basically the same thing. So we want to do a chest X-ray to rule aortic dissection out. And usually you see that on the chest X-ray, you see a large aortic silhouette. PE also presents with shortness of breath and chest pain, so we want to make sure that's not what is happening with a CT scan. My working diagnosis for this case study will be a STEMI. My etiology and pathophysiology of STEMI, the most common cause of decreased coronary blood flow is formation of plaques in the coronary circulation. Some plaques are unstable and prone to rupture or ulceration, and when this happens, the underlying vessels are exposed, resulting in platelet adhesion and thrombus formation. Thrombus formation can suddenly cut off blood supply to the heart, resulting in acute myocardial ischemia. And usually when ischemia, it takes about 10 seconds of occlusion for ischemia to happen. So we want to pay attention to how long the symptoms start, how long ago did the symptoms start. And actually takes, if you have the myocardial ischemia for greater than 20 minutes, then resulting in MI. So MI occurs when there is prolonged interruption of coronary blood flow greater than 20 minutes, which results in myocyte necrosis and death. The duration of the ischemia determines the size and character of the infarct. Ischemic myocardial cells also release catecholamines like epinephrine and norepinephrine, which can elevate blood sugar. So we want to pay attention to the blood sugar because they might get hypoglycemic. This is just a picture of the artery, and then this is the normal artery. You can see it's clear and blood can flow through easily. This is a diseased one. You can see the clot right there, and then this is the plaque. And you can see blood cannot go through it. So this is really what is causing the MI. This is just another picture of it. I just wanted to go over like the difference between a STEMI and a non-STEMI. A lot of people don't know the difference. If the thrombus breaks up before complete distal tissue necrosis, the infarction will involve only the myocardium directly beneath the endocardium. This infarction is a non-STEMI and usually presented with ST depression and T-wave inversion. However, if the thrombus lodges permanently in the vessel The infarction will extend through the myocardium all the way from endocardium to the epicardium, resulting in severe cardiac dysfunction. This infarction is a STEMI, and it causes marked elevation in the ST segment, and this is the most dangerous one, and it needs to be treated urgently. And if you look on here, you'll see this is a normal EKG right here. You see the P wave, this is a QRS wave, and then this is a T wave right here. See the normal ST segment is right here. Now for non-STEMI, you see the depression right here, P, Q, R, S. Then you can see how it's supposed to start right here, but it's all the way down here. So this is ST depression, and it's a non-STEMI. Now this is the STEMI. You can see P wave, Q, R, S. And you see how the ST segment is elevated, and it looks like a tombstone. This is indicative of a STEMI, and this is very. You need to treat this very urgently. Signs and symptoms of an MI. The first sign of MI will be sudden severe pain. Some patients describe this as an elephant sitting on their chest. In this case, our patient had some radiation to the back, and it might radiate to the neck, to back, jaw, shoulder. Nausea and vomiting may occur due to reflex stimulation of the vomiting centers by pain fibers. Infarction often stimulate a sensation of unrelated digestion. Heart rate and blood pressure are temporarily increased due to systemic nervous system activation for compensation. Abnormal extra heart sounds reflect left ventricular dysfunction. Cardiac murmurs, in this case we did hear some, may indicate acute valvular insufficiency. Pulmonary findings of congestion, including dullness to percussion and inspiratory crackles, can occur if the individual develops heart failure. And we did hear some crackles and rolls on this patient. Skin may become cool and clammy due to peripheral vascular constriction. The goal of treatment, we want to relieve the pain, the ischemic pain. We want to assessment of hemodynamic state and correction of abnormalities that are present. We want to initiate a perfusion therapy with PCI or fibrinolysis as soon as we can, because it could get tissue death can occur really fast. Cabbage if the PCI fibrinolysis has been unsuccessful. Anti-thrombotic therapy to prevent rethrombosis or acute stent thrombosis. We also want to start on a beta blocker to prevent ischemia and life-threatening arrhythmias. Plan of care. When a patient presents with an MI, we want to start them on an aspirin, non-coated aspirin. We want them to chew it, because if they chew, it's going to increase the absorption rate to the blood. So it's going to get faster, and then it's an antiplatelet, so it's going to help break down the clot. Oxygen, we want to give them oxygen 2 to 4 liters per minute with the patients that are their O2 sat less than 90%. So you see why we needed to know what her O2 sat was. Or patients in respiratory distress. Now, research has shown that patients that have O2 sats greater than 94, we shouldn't give them oxygen, because in a VOID study conducted in 2015, 441 normal oxic patients, which are patients that have O2 sat greater than 94, and have a STEMI, showed that the group that received oxygen had a larger size MI. So we don't want to give patients that have normal oxic oxygen, because it might lead to hyperoxia. Also, nitroglycerin tablets, 0.4 milligram every 5 minutes times 3 doses. In this case, they already gave her those 3 doses, so we might be thinking about switching to IV if the pain is still there and she's having any kind of hypertension is still there. Also, with the nitro tablets, we want to make sure that they have not taken any phosphodiesterase inhibitor drugs like Viagra, because those can cause severe drop in blood pressure. We don't want that. Morphine is another drug that is used for pain, 2 to 4 milligrams IV, increments of 2 to 8 milligrams repeated at 5 to 15 minute intervals. Also, recent studies have also shown that if we can, we should try to avoid morphine as much as we can, because it interferes with the antiplatelet effect. And in a study conducted, 57,000 people enrolled in the Crusade initiative, and those treated with morphine had higher risk of death than those that wasn't treated with morphine. Reperfusion therapy, we want to do a PCI or fibrinolysis, then a bypass graft if they didn't work. Beta blockers within the first 24 hours, and if no contraindications exist. For this patient, she did have some signs of heart failure, so we're going to start them on a slow dose of metoprolol, 12.5 milligrams per day, and increase it slowly. We want a high intensity statin therapy to be initiated within 24 hours because statin helps to decrease, it helps to stabilize the plaque. So, and it helps to decrease the formation of the plaque. So we want to start them on high intensity statin therapy. We want to give them beta blockers and electrolyte replacement because these help to prevent the arrhythmias. We also want to avoid the IV lidocaine or IM lidocaine because it's not recommended. I want to talk about the PCI versus the fibrinolysis and CABG. PCI is basically like a non-surgical procedure where they go in through your groin and then go through your heart and open up the blood vessel to your heart. And if available, multiple studies have shown that it has survival with and lower rate of intracranial hemorrhage and recurrent MI when compared to fibrinolysis. So American College of Cardiology Foundation recommends the use of primary PCI for any patient with an acute STEMI. Fibrinolysis is basically an enzymatic breakdown of clots using IV thrombolytic agents. And the American Heart Association recommends the use of fibrinolysis in patients with symptoms onset within 12 hours who cannot receive PCI within 120 minutes of first medical contact. So basically, if the patient comes in complaining of chest pain and you can confirm that it's a STEMI, but your staff in the hospital is not equipped enough to do the PCI, you want to transfer them, and you can't transfer them fast enough, you want to start with the fibrinolysis. Now, CABG, they don't really do CABG that often because of the increased mortality rate with CABG in the first 3 to 7 days. So the only indications are usually if the PCI fails or the fibrinolysis fails. This is just the PCI. It shows how it goes through the groin. This is just a picture. It goes from the groin right here, and then you see the blockage, and then it just opens up with the stent, and then blood can flow through it. Monitoring, you want to put the patient on a continuous cardiac monitoring right away. You want to have a crash cart available and ready for use because you never know if they might code. You want to monitor electrolyte imbalances and replace them as needed. Monitor blood sugar and monitor blood pressure and other vital signs. Continuity of care. Patient needs to be kept empty, nothing by mouth for the first 4 to 12 hours. Bed rest and DVT prophylaxis with anticoagulants. We also want to give them stool softeners to eliminate need for straining because straining could cause bradycardia and that could in turn lead to cardiac overload. We want them to follow up within 3 weeks of discharge for reevaluation and we want a tight blood pressure and sugar control. Education, we want to teach patients that they can resume sexual activities in 10 days and we want them to engage in mild to moderate exercise consistently as tolerated, and they should also avoid rigorous exercise. They can start driving again in a week after discharge, and they definitely need to avoid smoking, drinking, or use of any illicit drugs. Educate patient on needs to prepare healthy foods with more fruits and green leaf vegetables. Low fat diets, low sodium diets, less than 1.5 grams per day, and avoid caffeine. Teach the importance of weight loss. In this case, she's a little bit overweight, so we want her to lose some weight. And also educate her on the need for strict adherence to the medication because it's obvious that she was not really taking all her meds in the right way because her lipid panel was high. Long-term care, we want to schedule patients for echo to assess for heart failure and need for ICD placement, especially when the ejection fraction is less than 30. Consider exercise-based cardiac rehabilitation program and continue to assess for depression and treat with SSRI or psychotherapy because studies have shown that depression occurs in 20% of patients post-MI. We also want to give them the annual flu shot and pneumonia vaccine every 5 years to make sure they don't come back to the hospital unnecessarily. And that's it. Hope you guys learned something today. Thank you so much for listening to me.